Hello friends, welcome to another video on critical appraisal for emergency medicine. My name is Dr. Sajjad Pathan and today we shall have some basic understanding of how we do a critical appraisal of a research literature. So the objectives in this scenario would be, we'll take you from here, which is dry and deserted place, and try to make this topic, which is actually dry and deserted, into something which looks much beautiful, and we'll try to make that change. Okay? Why is critical appraisal important? Why do you need to learn this? It is because, let me give you two scenarios over here. A 25-year-old male is come with chest pain for 2 hours. He has no comorbidities, no family history of ischemic heart disease. He's never seen or touched tobacco. His ECG is normal. What would you do next? And the other scenario is a 78-year-old male with history of chest pain associated with sweating is in your department. He has past history of hypertension, diabetes, ischemic heart disease, which required a percutaneous intervention, and then later a CABG. He still smokes 2 packs of cigarettes per day. His younger brother died of an MI at age of 33. His ECG is unreadable. What would you do next? If you notice, this is a very clear-cut scenario. In the first scenario, you are making an assumption based on his presentation and his past history and assuming that ECG is normal. He very unlikely has a myocardial infarction or heart-related event. Whereas in the second scenario, even though you do not have a properly readable ECG, you are making an assumption that this person has a high likelihood of a coronary event over here, right? So let's make it a bit trickier. Now here's a 49-year-old who comes in with central chest pain for last 3 hours. He has history of hypertension, diabetes, which he's medicated for. He quit smoking 7 years ago. His father had an MI at the age of 50. His ECG is normal. What would you do next? In short, what we have done is we have applied a concept of Bayesian theorem. We made a pre-test probability of a condition and then multiplied it with the likelihood ratio of the symptoms or the test and come up with a post-test probability. So in the first scenario, you did the ECG. ECG was normal. You didn't want to do a troponin. You wanted to send the patient home. In the second one, even though ECG was unreadable, you wanted to do a troponin to confirm your diagnosis. The pre-test probability of that condition based on his presentation was way high. And even if the troponin would have come back slightly raised or normal, you would have still thought, oh, this is an unstable angina. And your post-test probability will still be high, even though the likelihood ratio of the troponin was low. So what we did, we used some form of statistics to make your decision. Did you ask for an enzyme? Why? Did we just apply the Bayesian theorem in all 3 scenarios? And how we do it, there is a nomogram on which we have pre-test probability on one side, likelihood ratio in the middle, and then we draw a line showing how likely the post-test probability of a condition is. This is Bayesian theorem, and we use statistics, we use the knowledge of critical appraisal in your day-to-day practice. So what is critical appraisal? Critical appraisal is an important element of evidence-based medicine. Critical appraisal, it is the process in which you systematically examine research to judge its trustworthiness and its value and its relevance in a particular context. So on a daily basis, thousands and thousands of papers are published. Will you accept all of it, or you will keep a critical view towards every paper and examine it in detail and come up with, oh, this paper is likely to make a change in my practice, whereas all this should go in the bin. That is what is critical appraisal, and you will use it till the end of your practice. It requires a basic understanding of basic statistics. You need to understand various study designs. You need to understand the level of evidences and how do you dissect a research work. So what are the types of literature we come across? We come across various diagnostic trials, use of ultrasound versus conventional clinical diagnosis, use of a particular test versus another test. These are diagnostic trials. Then there are therapeutic trials in which one group gets the gold standard treatment, the other one gets the intervention treatment. And you may come across something we call it as meta-analysis, where an author takes all the papers or diagnostic or therapeutic which are published based on the topic of interest, and then he analyzes their results and come up with a meta-analysis. So we need to understand the ranking, the grading of the literature work. So let's assume I'm an expert in emergency medicine and I come around and say doing this is necessary for this diagnosis. Now this is an expert opinion. How valid it is, or what would be you grade it as? You will, in critical appraisal, an expert opinion is of the lowest grade. It comes at grade 5. It is much lower than observational studies or literature review or case reports. So we need to understand the grading of recommendations. First one is a systematic review, which is like a randomized controlled trial, which you read. That's grade 1. Grade 2 is studies which do not do randomization, just a controlled trial, but there was no randomization of any sort. And third is observational studies or case control studies. Fourth would be the observational studies such as case reports or case series. And fifth will be my opinion. Then there are strengths of recommendation. So from one paper, you decide, okay, this is going to be changing the practice. Well, what would be the grading of that? So in strength of recommendations, we say it's a grade B recommendation or it's a grade C recommendation. What do you mean by that? So when I said an expert opinion was of the lowest grade, same thing will be the strength of recommendation, grade D. Here it was 5th grade, here strength is D. Grade 1 in the type of paper was a meta-analysis or systematic review or randomized controlled trial. Here the strength of recommendation would be grade A. B is based on level 2 or 3 evidences like studies without randomization or a well-designed observational study, case control cohort study. And the grade C is based on a case series. You don't have to memorize it, just try to understand it that the best study is a randomized controlled trial. And the least important one is somebody like me coming up with an expert opinion or giving you an expert advice. Let's go to a little bit basic. What do you understand by research? Research, if you divide this word into 2 parts, it says re and search. So somebody has searched some evidence. Now based on those evidence, you are either trying to challenge it or you are trying to strengthen it by doing your own search. So you are researching the evidences to either challenge it or to strengthen it. The purpose is to answer a clinical question. It is not a single unit. You have to answer a clinical question, and it should be a very specific question related to a very particular presentation. If you notice the papers, what you will see is, first thing is you will notice the title of the paper. comparison of ultrasounds done by ED physicians versus a radiographer in DVTs. That's the title of the paper. Then you will see a short paragraph labeled as abstract. Thirdly, you will see the objectives of the study. Why did they do that? And then they will say the design. How did they design it? Like, when did they do it? Whom they included in the study? For how long did they do it? And where did they do it? By convention, if it's done in multiple centers with a good population size or a good power, it's a good study design. Then they will tell you this intervention was done and this control this was the control, this was the intervention group. Then they will tell you what were the primary outcomes they were looking for, and then the results, which are presented in a tabular form. Lastly, the author will come up with limitations and conclusions. Yes, so this is a basic structure of any paper. What is common is there is something called as consort diagram, which says a flow of subjects in the study, right from enrollment till analysis of result. That's a consort diagram. Demographic data is presented in table 1. Results are presented in the results column, and then there are further tables given. And lastly, you will also see some charts. You need to understand how to analyze those charts. Let us look at these terminologies in detail. The title should be very clear. It should give an idea of the type of research question. An abstract does the same. It's like a trailer of the movie. So it gives you a gist of what is the big picture like. And it helps us in triaging our topic of interest. So if I pick up 10 papers, I don't have to sit and read all of them. What I do is I look at the title. Does it make sense? Secondly, I'll go over the abstract quickly and see if this is what I was looking for. If the abstract makes sense, then I would like to look at the whole paper. Otherwise, 9 out of 10 papers will be binned. Then comes the introduction. The introduction is just giving you some idea about the condition under study, what difficulties are encountered today, the epidemiology of the condition and other stuff. But it may talk about previous evidences and other stuff. If you look at the last line of the introduction part, it will tell you the clinical question. It will tell you the clinical question which is examined in this particular study. How would you design a study to answer this clinical question is the thing you need to start asking. So if I tell you I'm going to look at a paper where I'm going to compare the diagnostic accuracy of ED physicians for a point of care ultrasound for DVT, I need to have a gold standard. I have to see how I'm going to enroll, how I'll analyze my results. All these things should be coming immediately to you. And then when you are open up with your study design and see how the author has done, then you'll be able to point out or critically point out certain deficiencies in that paper. Then comes the methodology or the study design. So it's whether it was done in ED settings, a GP practice, outpatient clinic, where was it done? Is it pragmatic? I mean to say, is it real settings versus experimental settings? Population, how they were selected. Were they only interested in the patients who came to them in the ED, or they went around looking for them? So look at the table 1. As I said, it will tell you the demographic details. An ideal paper should also include a p-value or confidence interval next to each feature, and p-value in this should be insignificant. Then what inclusion and exclusion criteria were used? For example, the Ottawa knee rule or the ankle rule was studied on a population in which they did not include pregnant women. They did not include children less than 6 years. So Can I apply Ottawa rule to somebody who is 5-year old? No. So you need to look at what inclusion exclusion criteria was used. Was the sample size determined? Like, did they, before they enrolled, did they calculate the power? And what was the sampling method by which they enrolled these people? Then there are different types of sampling methods. I want you to go Google these definitions and try to understand them. Random sampling is just to pick up anybody randomly. Systematic is, okay, we are going to take the first, fifth, 10th patient, or first, third, fifth patient we'll enroll in our study. Stratified, okay, we are just going to group these people, stratify them as high risk, low risk people. So cluster in a group of patients here in this hospital, this hospital, this hospital. So we will determine the clusters. Convenient sampling is something which is easily available at hand. So if somebody is taken only patients while they are working, that is a convenient sample. So if I'm on shift, I'm enrolling them. If I'm not on shift, I'm missing certain candidates. Convenient sampling can give rise to sampling biases. So we need to know whether the sample is actually representative of the population, because in general, we are going to do a test or research on these people who have come to us. Now, if there were 1,000 people, are they representing the whole bigger lot of your population? That means in future, will this population which is coming now will be the same? You need to compare the baseline characteristics in the demographic table and look for confounders. Look for confounders. Then you see the intervention and comparison group. Look at what intervention investigation we are doing. Is there a control which is appropriate, and is there a gold standard which is appropriate, right? Then we want to look at what outcome we are looking for. It should be clinically relevant. We are going to look at a primary endpoint. It should be reliable, valid, and responsible. At times we are not able to take the primary endpoint. So what we do is we take something which is close enough to that. So it's called as surrogate endpoint. So rather than looking at mortality, we can look at a confirmed diagnosis in a live patient and say that this could have led to mortality if not treated. Then when did they enroll the patient, for how long, and how did they follow up these patients? Did they try to just look at the hospital data? Did they give them a call 3 months down the line? Did they check the death registry? Did they check? So this is the way you follow it up. A thorough follow-up should be mentioned. Otherwise, you might miss on certain cases which will not be included in the analysis and which will lead to attrition bias. The results should tell you the numbers which were enrolled, numbers which were excluded. It should also tell you dropouts, the loss to follow-up, compliance, whether the study was properly done. There were no protocol violations. And as I said, consolidated standardized reporting of trial, which is a consort diagram, should be there. Look at the statistics, what tests were given. In therapeutic studies, there should be mention of relative risk, attributable risk, number needed to treat, number needed to harm. In diagnostic studies, they should include terminologies like sensitivity, specificity, positive predictive value, negative predictive value, likelihood ratios, or C statistics. And then look at the p-values and confidence interval. I'll come to the p-values and confidence interval later. Let's move ahead and see the discussion and the conclusion. In the discussion, the author should present with the limitations. If they haven't, then you should look for the limitations. Does the author's conclusion matches yours? Are there any issues with validity? Validity means internal or external validity. Internal validity means, were there any biases in the study design itself? Were there severe deficiencies in the study design? External validity is like, will you be able to reproduce this study somewhere else? Look at the biases, the clinical question. Is it important? Doesn't matter. Literature review. Did the search, when they did a meta-analysis, did they include every kind of paper? Or did they mention, they just included studies done on humans between this and this age group, reported in English. So we are missing Spanish, French, other language studies which are published. So that should be mentioned in the limitations. Then sampling. Was it a convenient sample use? Were there too many inclusive and exclusion criteria used, which will lead to something called as a diagnostic purity bias? Then was the right tool used to check the instrument bias? Then was somebody, like some people, lost to follow up? That will lead to attrition bias. So in that case, in order to avoid the attrition bias, what we use is intention to treat analysis rather than per protocol analysis. So in intention to treat analysis, what we do is we include everybody in the result, whether they have completed the trial or they have been lost to follow-up. Everybody is included in the analysis. That is the intention to treat analysis. Whereas per protocol analysis is only those people are included in the analysis who completed the trial. So both has its positive and negatives. We'll come to it in a bit. So let's apply. Will I be able to, after reading this paper, will I be able to change my practice? Should I? If this paper is on, imagine an adverse effect of an anti-rheumatic drug, for example. Is it relevant for me if I'm practicing in the emergency department somewhere in the interiors of a developing country? So there may be rheumatic conditions in the interiors of the country, but not all will have the privilege to get treated by the modern drug. So does it matter to me? No, it doesn't matter to me. I don't want to read about that paper. I'm not interested. Then are there any badness to any intervention mentioned? For example, ultrasound, it's not bad. However, it has the badness. It is operator dependent, right? CT scan, it's not bad. It has the badness. It has the badness that it gives you too much of radiations. So you need to think of that. You will say CT scan as the gold standard for diagnosis of appendicitis versus clinical diagnosis. Then then you come and say to the department, okay, from today we are going to, for all suspected appendicitis, CT scan is a must. Now you need to weigh the pros and cons. I don't want to scan a 5-year-old, 6-year-old based on just a moderate suspicion of appendicitis. So there is badness. You need to consider them. Then you need to consider the budgeting. For example, how will I buy an ultrasound machine or a new anti-rheumatic drug? Will it be feasible for me to use it in poor people? So you need to see if it matters. Then there will be barriers, such as the barriers and beliefs. Old-time practitioners or your senior colleagues may not amend to do things which are done commonly. They may have a rigid practice pattern, so it may be difficult to implement in these population. So before applying, consider all these factors. Then comes, look at the author. Look at the status of the author. Look at the status of the journal and the institute. It will play a role. Somebody who's experienced in emergency medicine writing a paper on rheumatology, do you want to read it? An emergency department publishing a paper on family medicine, do you want to read it? No. Then are there any financial conflicts of interest? And then look at the reference. Are they valid? And this way you can actually analyze that whether I want to read this paper further or not. Thank you for now. We'll discuss these topics in detail in the coming videos. Have a good day.